Welcome everyone to today's webinar, Revolutionizing Utilization Review for Greater Sustainability. I am Ayla Ellison with Becker's Hospital Review. We will begin today's webinar with a presentation and we'll have time at the end of the hour for a question and answer session. You can submit any questions you have throughout the webinar by typing them into the Q&A box you see on your screen. We are looking forward to hearing your questions. Today's session is being recorded and will be available after the event. You can use the same link you used to log into today's webinar to access the recording. At this time, it is now my pleasure to start today's webinar by introducing our presenters. Tiffany Steffen currently serves on the Hospital Performance Improvement Team for Optum. She brings more than 23 years of experience in acute and outpatient care to her role with Optum. In this role, Ms. Steffen is responsible for inpatient care management, service line services, and development. She assists hospitals in the improvement of efficiency and effectiveness of clinical operations, evaluating productivity, improving throughput, coaching leadership, and redesigning processes. Prior to joining Optum, Ms. Steffen served as System Director of Care Management and Chronic Care Programs at ProHealth Care in Waukesha, Wisconsin. Chris Carter is the Senior Director of Implementation and Client Education for Optum Physician Advisor Solutions, providing project management and consultative services to hospital and case management leadership. Prior to working at Optum, Mr. Carter was the Director of Nursing, Case Management, Critical Care, and Patient Flow at an acute care center in Maryland. Dr. Kurt Hoffensberger currently serves as Vice President and Regional Medical Director at Optum Physician Advisor Solutions, a national organization that provides technology-enabled expert physician advisor teams. Prior to joining Optum, Dr. Hoffensberger developed an accomplished career as a neurologist, serving as the Medical Director of Patient Safety and Chair of the Employed Physician Group at Cheyenne Regional Medical Center, as well as in private practice. At this time, I am pleased to turn the floor over to Dr. Hoffensberger to begin today's presentation.
Well, thank you, Ayla, and either good morning or good afternoon, depending on what part of the country you're in. I'd like to go over our agenda here briefly. What I'd like to accomplish today is to start with an historical perspective on case management and utilization review, and that will be courtesy of Tiffany Steffens, and how this world and this realm is changing, and most importantly, what is the impact of utilization review and what are the barriers to high performance in utilization review and case management as well. Then we'll switch gears a little bit and we'll talk about the application of artificial intelligence to the utilization review process. I'll cover some theory and some general concepts about artificial intelligence as well as how is its difficulty in applying it to the realm of medical review. And then I'm going to turn it over to Chris Carter for talk about real-world application and examples of artificial intelligence in the UR process. And following that, as was mentioned, we will have a question and answer session for everybody as well. To sort of set the stage about this, hospitals and hospital administrators are being pulled in many directions, and utilization review is only one area which is competing for their attention. However, utilization review and the patient status that results from that review is usually a pretty significant factor in the financial health of many institutions. Many institutions are operating, for example, at single-digit margins, and certainly that patient status can be a major determinant in what that single digit may be. Others may be more fortunate than having single-digit margins as well. But many times the challenges facing the utilization department are not always apparent to administration. And some of these facts on this slide, courtesy of the advisory board, I think are something of an eye-opener. For example, if you look at medical necessity denials versus denials for other reasons from commercial insurers, they are up from 12% in the fairly recent past to 20% of all denials based on patient status and medical necessity. On the same token, or on the other side of the coin, commercial denial appeal success rate tends to be dropping. And it is down over 20 percentage points to an average of about 45% overturn rate on commercial appeals denials. And I think it's pretty fair to say that payers continue to ramp up clinical teams to contest patient status decision. And I think all of that leads to the conclusion that more than ever, providers need to get patient status right for proper reimbursement. So the UR process is under a lot of pressures, but it actually is more important now than it has been, I think, in the recent past as well. So sort of setting the stage with those facts and that impression, at this point I'm going to turn it over to Tiffany Steffens. And Tiffany, go ahead and please take it away.
Great, thank you, Kurt. So yeah, we're going to start just a quick high overview of the utilization management and case management history. So if you look at that, you can see it can be traced back to the early 1900s. Formal acute case management is really relatively new as we see it today. It really began to emerge in the early 1980s with the establishment of DRGs. Organizations responded by developing the case management role in the hospital to manage patient care and start to contain costs. So really, if you think about that, that's really not that long ago. In the 1990s, there was a greater emphasis on with the growth of managed care. So organizations were starting to look at ways how to contain costs by length of stay and getting earlier discharges. And it was at this time that the CMSA actually developed the first standards of practice. Then we move into the 2000s and where we are today, and we have our movement into population health and how are we to manage patients across the continuum versus that episodic care. It really is all down to the ultimate goal of what is the triple aim, how do we enhance patient experience, improve our population health, reducing costs, and improving the work life of our healthcare provider. So case management is a driver to controlling costs and leading the change for improvement. And you'll see in these 4 squares, these are great opportunities for case management impact. The questions that we ask when we look at this is, do we have protocols and order sets in place? Are the providers following the protocols and order sets? Are the services or procedures that are occurring in the hospital setting appropriate, or should they be done in the outpatient setting? And then the few of the larger trending metrics that we measure are the excess days, avoidable admissions, readmissions, and how we're making that impact. We call this our chaos slide. So this is just a representation of only some of the multiple demands placed on case management today. All of these components are connected and impact each other, which you would say adds to the chaos. So for example, getting the patient status right from admission and getting that patient into the right level of care, we're continuing to manage that patient's progression through the hospital stay with reevaluating, do we still have them in the right level of care? Are we utilizing our resources appropriately? What is the transition plan for that patient, all while we're trying to work with our payer to understand what they're approving or denying. So needless to say, this is a very complex environment to navigate in. So not only do we have health system complexities, we have government policy. So here are listed some of the recent drivers of government policy changes. CMS has implemented many new regulations, and they are difficult to interpret. So for example, one of those examples is that 2-midnight rule. Just recently, I was reading an article about a physician advisor who was notified by one of their MA plans that was not going to follow the 2-midnight rule any longer because CMS was going to remove it. Well, the MA plan had a misinterpretation of an update from CMS. So it's just proof that it's a challenge for all parts of the healthcare industry to understand. And please note, the 2-midnight rule is not going away. One item that I think we can all agree upon is that there's more regulation and changes coming ahead. The other area that we find very challenging for organizations is the value-based care initiatives. Organizations end up having they have 2 camps, 1 foot in for volume and 1 for a value payment. As we look for trends in the commercial payers, Organizations across the country are experiencing increasing the medical necessity denials across payers, and this includes both those retro and concurrent denials. One area that we hear frequently is the push to place patients in observation. However, the organization feels the patient really is meeting medical necessity for inpatient. This has created more work for the organizations, and how do they, when they want to do what's right for both the patient and themselves. We are seeing some areas of the country and organizations moving aggressively to shared risk contracting with payers, and this has changed the landscape dramatically for these organizations, and they need to look more broadly and quickly at how case management is defined for them. Every day we're seeing headlines that technology is emerging to provide better care for our patients and how they receive care. One example that we see frequently is the building of predictive modeling into the EMR to determine who are the high-risk patients for readmission and developing the algorithms to guide patient care. These algorithms are being developed for both inpatient and ambulatory case management. As technology continues to evolve, develop, and get implemented, it will change the way case management functions, gains efficiency, and the standardization of processes. We will need to embrace these changes as they emerge. Both Kurt and Chris will be discussing the AI later in the presentation, just exactly how this impacts our case management and physician advisor role. So what have been the challenges to having a high-performing UR process? This list will look familiar to you. As you'll see, case managers struggle with determining the priorities of the day. Is it discharging patients or the UR review? Do we have the right level of expertise in our organization to make medical necessity decisions and base them on evidence-based medicine? This is usually compounded by having high volumes of case data. Is it accurate? Have we been able to develop a process that it's not got errors in it? In addition, how do we manage all of this with tight staffing resources, and how do we not have fragmentation in the process with gaps in coverage? So let's review how some organizations that we're seeing across the country rethink how they're using clinical resources. So if we think about realigning the expertise, this slide really shows at the top, on that top arrow, we need the right resources at the right time, as well as having the right knowledge and data in a parallel process of having that it being efficient as well as being accurate. And that's how we're going to get to that high performance utilization review. Although case management can't do this alone, they should be the drivers in the driver's seat in facilitating this work. Case management has the highest vantage point of connecting all these dots. So when you think about, as an organization, in coordinating care for patients, case management should be partnering with patient placement, transfer centers. How are patients arriving to your organization, and are we touching those patients as they enter to make sure that they're in the right level of care and patient status? How are you looking at transparency of what's been pre-auth for that patient prior to the procedure, and that it's sticking with that patient throughout their progression of care? And then denials management, really partnering with revenue cycle and having the transparency of what's happening with medical necessity denials and what processes within the organization need improvement. We're seeing much more emphasis on the care clinical documentation improvement, and also how do we partner with ED case management to make sure that we're having the right supportive documentation so we have the right level of status and level of care that will not require us to do more work on the back end. And then how do we continue to partner with our managed care teams? Do we have the right contracts in place, right contract language that doesn't conflict with our care priorities and practices? And if we look directly at the case management department, we're seeing trends to move case management staff to top of license by adding in some support staff for case management associates. We're seeing that UR is expanding outside of just the inpatient units. It's to be including post-procedural patients, surgical patients, patients that transfer into our hospitals. There's a shift back to dedicated ED case management staff with extended hours. Case management's no longer a Monday through Friday 8 to 5 function. Really need to be thinking about how we take care of patients 24/7. We're also seeing the expansion of the physician advisor role to include quality initiatives along with their denials management, coding, CDI responsibilities that they do today. And we're also lastly seeing the use of AI and making a powerful impact to gain efficiency within the case manager and physician advisor role. I'll now turn this back over to Kurt, who will discuss what we're seeing. Thank you.
Well, thank you very much, Tiffany. And I want to transition now into start with sort of the theory and the application of artificial intelligence to case management and in general to medical record review. And then, as I mentioned, I'm going to turn it over to Chris for some real-world experience there. If you look at the slide I've got up now, this is a poll by OptumIQ from last year where we polled senior healthcare industry executives, and about 94% of them saw artificial intelligence as the most reliable path towards affordable healthcare. And I think that makes a lot of sense. If the goal, or if one of the goals, is removing inconsistencies and removing errors in those parts of the UR process that actually can be improved through the use of automation and artificial intelligence, you can also retain human experience and judgment where needed in the process as well. So it works hand in hand with review also by, for example, clinicians, physician advisors, et cetera. So just sort of some background now about what is actually artificial intelligence. And as you can see, I think it's useful to break it down into two major types of AI, natural language processing and machine learning or deep learning. But the so-called problem domain, the so-called area we're applying artificial intelligence to, is quite a bit different from some other applications that you may have seen it used in. Artificial intelligence in the world of medicine is different from, for example, image recognition or facial recognition. Certainly that's been in the news quite a bit about the use of facial recognition, even to substitute for boarding passes for certain airlines. And certainly in other countries, facial recognition is very widespread. Self-driving cars, for example, a form of artificial intelligence and pattern recognition, or even something as relatively mundane as recommending products on shopping websites based on your history or based on what you've purchased before, et cetera. Medical information, it's pretty obvious, is much more complex than many of the other areas where artificial intelligence is currently used. And one of the other things that's such a challenge with artificial intelligence with use in medical information is a combination of hard facts and numbers. For example, a patient's serum creatinine or an anticonvulsant drug level, along with a clinician's interpretation of how important those facts are, along with textual descriptions. For example, the patient's medical history or something unique about their presentation or something that you're going to quote the patient on as to how they view their symptoms, or a description of the physical exam. So you have a problem here of not only hard facts and numbers, as I mentioned, radiologic results, laboratory results, et cetera. You have the interpretation of those numbers, and then you necessarily have, for example, the clinician describing the history, the physical, et cetera. So that really requires two approaches to artificial intelligence. The first one, as you can see, is actually at the bottom of the slide, is the machine learning, the deep learning, and that's actually feeding your artificial intelligence model of lots and lots of data so that it can work out what the correct result is when it analyzes those, but then also looking at the textual information, that history and physical, that description of the history, et cetera, using what's called natural language processing. And that's, in a sense, the computer's ability to understand the importance of words, generally in English, of course, and how they relate to other words, et cetera, to try to find the weighting of those as well. So it's a difficult problem. and it requires something more than just a simple solution to get it right. If the goal is training the artificial intelligence model, which it is, of course, you need vast quantity of clinical inputs so that the artificial intelligence can understand the context of words in the free text areas of, for example, a history and physical or an emergency room note, and can also understand the weight of those terms and can understand how those terms relate to terms near it, for example, in the text, or terms that negate it, for example, in text as well. And this is just kind of a graphical way looking at a lot of terms as to how the weighting might be viewed kind of visually, in terms of darker weights give more importance to the term, lighter weights give less importance to the term, again, based on its position in the sentence, its position in relation to other words, and whether negating terms and the context of the concept as well. And moving on, I think it's safe to say for the machine learning part of artificial intelligence, and this is, of course, in addition to the natural language processing that goes on, you really need at least three things to be very effective. And the first thing is you need a vast amount of source data. Ideally, as much source data as possible, and of course, in the world we're talking about here today, that means a vast number of clinical documents, emergency room notes, histories and physicals, et cetera, laboratory studies, whatever it may be. And for that reproducibility and for the accuracy of that artificial intelligence, I would suggest, when I say vast quantities, you probably are looking at, for example, even having a library of millions of records available for that artificial intelligence to really be trained adequately on that. And then the second thing is you need that source data to be well-defined and well-classified. Ideally, that source data would be broken into diagnostic groups, for example, when looking at medical records and history and physicals, and you would also have a clear outcome for each case to train your model. For example, diagnostic group would be listed, would be available to the AI model, then the entire history and physical, emergency room notes, et cetera, and then a clear determinant of what that ended up as with experts providing the answers. For example, did all of that information, the diagnosis as well as the history and physical, emergency room, et cetera, did all of that equal an inpatient recommendation legitimately and reliably, or an observation recommendation when we're talking about applying this to utilization review? And the third item is that you do need your data to be distributed and representative. And those are both kind of two sides of the same coin in terms of how the data should be for the source model as well. You have to make sure that the histories and physicals and emergency room notes and whatever else you're putting into the model really represent the real-world problem domain. In other words, they should really reflect what a particular institution or hospital's pertinent population is. But on the same hand, it should have enough variety that it can, in a sense, handle or can, in a sense, analyze almost all the types of cases from that institution as well. So you want it to have a similar distribution as to what is seen in most institutions, but also be able to handle those areas that represent not so common cases as well, and do a good job on those too. And I want to emphasize that although the application of artificial intelligence in the utilization review and case management world, the so-called second wave on this slide, I wouldn't say it's new, but it's relatively new. The entire concept of using artificial intelligence to analyze medical records has actually been around quite some time, pretty much close to 2 decades. I know, for example, Optum has been using artificial intelligence in computer-assisted coding and clinical documentation improvement for close to 20 years. And now I think it is ready, and has been ready for a while now. It is ready to be applied to the utilization review and case management world, which is a similar but a different problem with a different result. It's taking even more data, perhaps, than in the computer-assisted coding world and CDI world, and trying to distill it down into a reliable and defensible recommendation for status. And so with that, I'm going to now turn it over for the second main part of our presentation here, and I'm going to turn it over to Chris Carter for his insight and his comments on the real-world application of AI to the utilization review process. So, Chris, I'm going to turn it over to you.
Thanks, Dr. Havensberger, and good day, everyone. What I'm going to go through here with you guys is, how is utilization review, how are AI and utilization review coexisting? How are they coming together? How is it impacting now the workflow associated with case management and utilization review? And what are some of the efficiencies that we've seen gained through that application? So as we've learned, artificial intelligence can mine for impactful information, making sure that, that the process of the front-end review can be a little bit more efficient and identify those clinical risk factors quickly without having to go through the vast data that is in a clinical medical record. And it helps to avoid that manual review oversights. And that's an important concept that we need to come to grips with, is that one of the, as Tiffany was mentioning earlier, one of the pain points in case management and utilization review is inter-rater reliability. And that's not just on the case management side, that also is associated with the physician advisor's review as well. So artificial intelligence can really impact an organization's inter-rater reliability in a very positive way, making sure that the same case is getting reviewed the same way with the same outcome, no matter which practitioner is reviewing that case, is really, really important in the world of case management and utilization review. And AI helps to relieve some of those pain points. It helps to relieve and some time savings associated with doing first-level review and setting cases up in first-level review. For physician advisors, it helps them, again, with their inter-rater reliability, and then the vast amount of information that they have to comb through to create that complex medical judgment, to create that recommendation for patient status. So a little bit more of a holistic AI-enabled approach here. What you see on the left-hand side is a patient or a case would come in. They would run initially through that deep learning model that Dr. Havensberger was just mentioning, that what we call case stratification, where as an automated review of the medical record is done through the artificial intelligence, and it creates a probability. High probability of patient, high probability of inpatient would go on to second level review, or for a physician advisor review. Those cases that have a lower probability of being an inpatient would not go to a physician advisor for review and would most likely be a likely outpatient case. So with that case stratification going on, you can see in the front end time savings that can save in the case management world at that point in time. And it allows for all the cases to get screened, all the cases to get looked at by the same mechanism, by the same intelligence, and it helps to determine what goes into that second level review bucket for that physician advisor. That's when the natural language processing portion of artificial intelligence really starts to come into play. So when the physician's applying their logic and coming up with their complex medical judgment, the utilization of natural language processing to mine through that data, to mine through that voluminous amount of clinical information, to highlight those areas where that patient is at an increased risk of morbidity and mortality, really succinctly makes their review of that medical record much quicker, much easier, and much more accurate. That physician advisor is able to create that complex medical judgment, make their recommendation, and you see no case left behind there. That's the ultimate goal, to make sure that we're advocating for every patient that comes through our doors in the healthcare setting, and making sure that they are all in the appropriate status based on the medical necessity of that medical record. What you'll see on this slide is a little bit of a time trial study that we've done on the Optum side. We did a time trial study on how long does it take most nurses to do a first level review of a case, and the average came out to 19 minutes. So if you had 500 admissions or 500 observation patients that came in during a month-long period, and you were able to remove that 19-minute initial first-level review from their workflow, you'd be saving that staff potentially up to 158 hours per month, allowing them to do what Tiffany was articulating on that chaos slide. All those other things that have fallen onto the plate of case management, all of those top of license skills that they need to apply to that patient population, length of stay management, readmission risk stratification, denials management, discharge planning. The discharge window is a fleeting window. It's just a small window of opportunity. We need to hit that window of opportunity to maintain our appropriate length of stay for that individual patient, and other high value activities that your case manager, including documentation. On that chaos slide that Tiffany was mentioning earlier, with all those activities need to be documented in the medical record as being done, so that it's clear and transparent to the rest of the clinical team. So all of those things have to be documented. We need to create time for them to create these documentations. What you see on this next slide here is a look at kind of like our physician advisors dashboard, or our NLP dashboard, natural language processing dashboard. And in the top left-hand portion, you can see recommended clinical groups based on the natural language processing scrubbing of that medical record. In the middle section here, you'll see clinical facts, as well as the high and low risk factors that have been identified by that natural language processing. And then you have the medical document on the far right-hand side. So this is what our physician advisors would be looking at in the case stratification and in the creation of a recommendation for you, our end client, as we're going through this. And that's how we create such good and to great inter-rater reliability in recommendations back to our clientele here. So you see that you in that right-hand section of the document viewer, you see highlighted sections. So as our clinician would click through these high risk factors, it would then highlight through in the medical record on this screen where it's indicated, where the documentation is indicated that that is in fact a high risk factor for that individual patient. So I just kind of wanted to share that with you guys as we kind of show you how we're utilizing artificial intelligence in our everyday work here at Optum. And now I'm going to go through a little bit of the use cases, the people who have actually utilized this solution, some of their outcomes. So what we have up here on our first slide here is a 400-bed hospital. And what we did was we looked at two different methodologies. We looked at their traditional approach of utilizing their physician advisors. And what they would do in a non-AI approach is they sent us, out of a 100 case sample size of observation patients, they sent us 17 cases for second level review. And the other 83% were not reviewed or seen by a physician advisor. That 20% error rate there, what you see is what we would have recommended as inpatient if we've seen all of these 100 observation cases. And then what you see on the right-hand portion of the screen is the new AI-enabled approach, where there's no case left behind again, where we're reviewing all of these 100 observation cases, but we're first reviewing it with our deep learning model, our case stratification. That case stratification will determine what needs to go to a physician advisor for review and has a high probability. So it's kind of the sorting hat, if you will. In that approach, we looked at that same 100 case sample size. 49% of those patients or cases would have been low probability and sent back to the client as not needing a physician advisor review. However, 51% of those cases would have been seen by a physician advisor straight from the artificial intelligence, referring that on to second level review. Again, greater accuracy, more consistency in the review process. No case left behind again. And then as we extrapolated it out larger to that hospital, that same 400-bed hospital, and implemented them live with the solution, what you can see here on this slide is that in their traditional approach, and this is a 4-week sample size, this is all cases that were completely seen through the revenue cycle. So this information is completely based on received remittance advice. So everything that's been processed, and we've seen the claims, saw what got billed, saw what got paid, saw what got denied. So I'll share those numbers here with you right now. In their traditional approach, you can see that they sent in 169 cases that basically failed first level screening criteria. Our recommendation back to them was 123 recommended inpatient, 46 recommended outpatient. Good process being followed here. Good return on investment down here at the bottom with that $505,000. The AI-enabled approach, it's a little bit more holistic. It allows us to review more cases, the right cases. So we saw 645 cases that came through with and got looked at by the artificial intelligence engine. 231 of those were seen as not needing any other physician advisor review, low probability, low scores. So we sent those back to the clients, and the remaining close to 400 cases there, a little bit over 400 cases, 414 if my math is correct, did go on to second level review for a physician advisor to be applied to that. 291 recommended inpatient, 123 recommended outpatient or observation cases. With looking at all of those cases, all the cases more holistically instead of the picking and choosing that can happen sometimes in case management departments of what goes on to second level review, you can see the incremental revenue here as the differential between the traditional approach and then the AI-powered approach, a $690,000 incremental payer revenue over a 4-week period. And then if you were to extrapolate that out over a 12-month period, almost $8.3 million for this one organization. Again, this is all information based off of what was billed for this 4-week cycle and what was paid for that 4-week cycle. So this isn't anecdotal information. This is actually what got paid to this organization. Using a different hospital example here, this 280-bed hospital, a similar approach. The prior 4 weeks of information, we saw a total of 47 cases come through for them, most of them with an inpatient already initial order. And we wanted to flip that a little bit for them. We wanted to take a little bit more of a look of their initial order observation cases. So in the AI-enabled approach for them, they sent in 278 total cases. But the vast difference that you see here, 84% of them with initial order observation, allowing the inpatient recommendation rate went up significantly because we're looking at the right types of cases. We're looking at the cases where the physician advisor can really impact the organization and the outcomes throughout the revenue cycle. The incremental revenue here was good, $122,000 for them, but moves to great. And this slide made me think of a book that we probably all read, is probably all on our bookshelves right now, by Jim Collins in the early 2000s called Good to Great. And this is how you move your case management department, or one of the ways, one of the tools that you can utilize to move your case management department from good to great, utilizing these results here. Because you can see by focusing on the right patient population, making sure that those patients get a complex medical judgment and review on their medical record, you can see that the return on investment jumped up significantly, right, from 11 to 1 to 15 to 1, again, all the way through the rev cycle. Some key trends for that 280-bed hospital here. You can see here their observation rates. AI-empowered model was initiated here, so you can see it starts to dip down as the observation rate dips down as they started to normalize in practice. And the key thing here is that the denial rate does not budge. It stays consistent. Even though you're more aggressive here in this model, you don't see an uptick in the amount of medical necessity denials associated with the case. So the cases are being adjudicated, the cases are being agreed to by commercial payers, and that's what this slide's indicating to you guys right here. If we were to extrapolate out that one 280-bed hospital to the rest of their system, what you would see would be a vast increase in their total potential opportunity. So it just increased by organization here all the way down through different sized organizations, different demographic prints, different patient demographics in each one of these regions. But for that 7-hospital system, $12.9 million in annual opportunity based on the extrapolation from their one, I would say probably flagship hospital in their system with good consistent process. Associated with that 280-bed hospital, one of the key things that it's important to note when utilizing artificial intelligence is creating trust in the artificial intelligence itself. So for that 280-bed hospital's data, we only had a 2% error rate in the initial case stratification, and that initial error rate can be attributed to one of 3 buckets. What you'll see is that most of them were in the second bucket, in my opinion, in looking at these cases on a regular basis. But those 3 buckets are the patient acuity changed after the initial evaluation. happens all the time inside of hospitals. Insufficient documentation is a problem that we've all dealt with for a long period of time, and it was, in this pilot as well, or this limited subscription, that insufficient documentation at the time of the patient arrival, at the time of the AI scrubbing for that clinical information. Without appropriate documentation, the artificial intelligence is only going to be as good as the documentation that it's scrubbing. So when you're doing your due diligence and kicking the tire, so to speak, on any artificial intelligence solutions for your organizations, make sure that you're understanding how their model was created, what they used to create their model, how much evidence went into the creation of their model, and this would come into a much more focus for you guys. And then, small percentage here, case advisor incorrectly classifying a case as likely outpatient. Didn't see nearly as much of that as we did the first two buckets here. And as we all know, the more accurate our patient status is, especially up front, the more appropriate our reimbursement's going to be, the more likely we're going to be able to keep that reimbursement as a healthcare organization. And then we have that reduction in any type of compliance risk with potentially inappropriate inpatients. So that's going to be my last slide for you guys today. I'm going to go ahead and turn the slide show back over to Dr. Hoffensberger for our last roundup and hopefully some Q&A.
And thank you very much, Chris, and thank you, Tiffany, for your earlier comments. Appreciate your sharing your knowledge and your experience on this. I'd like to wrap up the formal part of this presentation by just saying I think it's pretty self-evident that utilization review is evolving and must evolve in order to stay relevant and continue to be a contributor to various institutions, not only their financial success, but that also affects, of course, institutions' patients, copay status, et cetera. It reflects metrics, including quality, value-based purchasing, et cetera. There's a lot of effect down the line from just the determinant of a patient's status as well. I also think that artificial intelligence can, as I think has been shown, improve the accuracy and the consistency of the utilization review process. And I'd like to suggest that you really want to automate what can be reliably automated now. You want to also use that automation to free up valuable utilization review and case management resources for activities with a greater need at your institution, and use their skills and experience of the UR and case management department for those areas, and leave the automation to those areas that can be reliably automated, as I mentioned. And with that, I would like to turn it back over to Ayla for any questions you may have, and I want to thank the audience for listening to this.
Well, thank you, Dr. Hoffensberger, Tiffany, and Chris for that fantastic presentation. We will now begin today's question and answer session. Please submit any questions you have by typing them into the Q&A box you see on your dashboard, and we'll try to get through as many questions as we have time for. Throughout the presentation, there were several questions that already came through, so we'll go ahead and get started with those now. In the first question today, Dr. Hoffensberger, Chris, or Tiffany, please feel free to jump in and answer this one. The question is, if a facility uses AI, are there lists of specific words or phrases that are needed to facilitate accurate reviews?
Chris, I don't know if you want to take that or you want me to take a shot at that one.
I'll go first here, Dr. Hoffensberger, and then you can clean up any misconceptions here that I might put out there. So the answer to the question is no. It really is intelligent, as it says in its title. It does look at the context in which you are utilizing the sentence. It understands the contextual way that the sentence is structured, and then how you're utilizing the terms in that sentence. So there's no specific words that need to be utilized to make sure that it's being picked up. It is scrubbed on and trained on again, like Dr. Hoppensberger was saying, millions and millions of medical records and terminology that have been used all across the country. So no specific language needs to be used in my mind. Dr. H., anything to add?
And that's really good. And I just want to add, I think one of the nice things as you've gotten to is you do not need to retrain your medical staff to kind of be attuned to certain words that are going to be important for the AI. The AI really does learn from the existing records and the records going forward. So you do not need any retraining. Your physicians don't need to document any differently now. Most institutions feel their physician documentation could improve, but you certainly don't need to refocus them away from ICD-10 and CDI and so on to now also be concerned in any way that they have to change their documentation so that the AI will pick up certain terms and so on. That's all on the AI, and there is no need for any kind of physician training.
Thank you, Chris and Dr. Hoffensberger. We'll go ahead and move on to the next question now, which I believe relates to the part of the presentation that you gave, Chris. So I'll go ahead and direct this question to you to get started. It says you've listed several additional areas that care managers are responsible for. Of those, do you think there is additional opportunity to use AI in the various duties and roles for the case manager has?
Absolutely, in a future state, as AI becomes more and more robust in the field, in the specialty of case management and utilization review, we're inventing new ways to utilize this every day. So yes, I do see that AI will play a role. It will not replace, our good clinical judgment as case managers and advocacy role, but it can help us. It is a nice tool for our toolbox, and I do see it expanding into our specialty in the future.
Thank you, Chris. The next question also, it's related to AIs and driving review. So Chris or Dr. Hoffensberger, the question is AI driving more case reviews by your PA teams?
More.
Yeah.
So that was a little bit of a tougher question. Is it driving more? I would say it's driving more appropriate cases to the physician advisor for review would be the way that I would answer that question. Not necessarily more, but more appropriate. So we're not looking at that really, really low probability, cases. We're looking at those cases that we can impact. So we've been trying for a while to retrain ourselves to make sure that we're looking at the right types of cases and making sure that we're having an impact back for our client base. And I think this is a great way to make sure that we're impacting that client base on the right types of cases. Kurt, you have anything you want to add to that?
I think it's possible it could drive more reviews. And Chris, like you said, I think it's an institution or hospital by hospital kind of variable as to whether that might drive more physician advisor reviews. But when the physician advisors also have access to the AI and the NLP's review of the case, I think it makes it easier and more reliable and faster, perhaps, for the physician advisor to get to the meat of what they need when they're looking at a case. So physician advisors, just like case managers, are reviewing voluminous materials on every case. I mean, dozens, if not sometimes, in some cases, hundreds of pages. And so even if there are more cases, the fact that you can look at what the NLP feels is important, what's relevant, what is the highest scored area, the boldest areas, and concentrate on those, you can deliver, I think, a more accurate review in probably less time with it. So I wouldn't say, and I don't know what was behind the question, but if this was an idea that, oh my gosh, we're going to have to now double the number of physician advisors, I don't think we see that happening at all.
Agreed.
Great. Thank you so much for your insight there. I think that your answers were very helpful and will help provide some clarification there. We've had several more questions come in, so we're going to keep working through those. I'll go ahead and jump in with the next question, which is, by using AI, would this decrease the number of full-time employees needed for the case management department?
I can jump in here, and I would say no, because actually what we're experiencing across organizations is that there's much more work to be done, and we can refocus what case managers and utilization review teams are working on and being able to really manage other parts of patient care much more efficiently and better than we do today.
And I couldn't agree more, Tiffany, with that statement. There's a term that I've heard recently. It's called a type of license skills, and we utilized it in the presentation today. It allows us, for your organizations, to utilize your nurses and your social workers for their type of license skills more readily. So it allows them to utilize, what you're paying their salary for, to make sure that they're impacting your patient population in the most appropriate and type of license skill way.
Yeah.
Thank you, Chris and Tiffany. Moving on to the next question now. This question has to do with, it goes back to the natural language processing. So for natural language processing for the physician advisors, is the physician advisor asking questions of the data and looking for information to support clinical judgment?
Oh, well, I'll start with that and let either Tiffany or Chris kind of chime in. No, the physician advisor is not asking questions. The physician advisor is presented ideally in the AI NLP model. They're presented with the results of the analysis, and then they're presented with what are the relevant terms in the free text of history and physical emergency room note, whatever it may be. And ideally, and look at those terms, reference what they mean if they refer to, for example, laboratory values and so on. And of course, the physician advisor is still going to use judgment in these cases. That's the whole point of having a stratification of cases that really don't need a physician advisor review versus cases that do. Cases that do, the physician advisor is going to still use judgment. They're the safety valve. They're the final determinant. But they don't need to, in a sense, query the record. That's all done for them. They simply need to apply their experience and judgment to what's presented. And they may or may not agree. There's always the possibility that a physician advisor may feel that a different diagnosis is appropriate, or despite identifying lots of clinical issues that would suggest the patient should be, for example, an inpatient, they may have other reasons to recommend another status. But it's not query-driven. It is presented to the physician as an analyzed record. I don't know, Chris and Tiffany, if you've got some more comments.
Not for me, Dr. H. I think it's well stated.
Yeah. Yep, agreed.
Great. Thank you so much, Dr. Hoffensberger. It looks like we have time for at least one and maybe two more questions. So we'll go ahead and jump in with those final questions now. The next question, it just has to do with the initial determination. So this person wants to know, is the initial determination by the emergency department MD, the admitting MD, or both?
I'll start with this one, Dr. Hoffensberger, and please jump in. It's really both. The artificial intelligence and the case stratification or the deep learning really is looking at both early on the ED record, the ED note, ED physician note, as well as the dictated and transcribed H&P that's generally done after the emergency room. So you can get a very accurate case stratification score off of the ED note. We've tested all of these models, and it's just validated again with the H&P. So that's how things are kind of starting off easily from an emergency room perspective.
Yeah, I wouldn't add anything to that. Thanks, Chris.
Thank you so much, Chris. It looks like we have time for one more question, so we're going to go ahead and jump in with that one now. And this final question is, besides the high-risk words, is there any specific criteria that AI looks at when determining low risk versus high risk? And this person mentions that some insurance companies look at interqual or Millman to meet inpatient versus OBS.
So I don't know if I understand the question completely. So, you know, the artificial intelligence in the case stratification portion of it, as well as in the NLP portion of it, is not utilizing, you know, interqual or MCG guidelines. It's based off of, you know, again, millions and millions of reviewed and adjudicated records. That's what it's been trained on. So it doesn't utilize MCG guidelines or interqual. You know, it really does literally scrub and read your medical record, yield a probability score, and then also able to highlight those high and low risk factors based on that trained model of those millions and millions of records. I hope that answered the question. I'm not sure if I did.
I think you did, Chris, but I'll just add, I mean, in a sense, this may sound a little strange, but in a sense, the model is trained on, quote, truth, unquote, rather than a predictive model. Again, we've taken cases, and this is the way most AI models work, is we've taken cases where the actual outcome is inpatient observation, and then we let the AI figure out the ranking and weighting of various clinical data, various terms in the natural language processing, et cetera. And so it mirrors reality, I think, better than, for example, just a list of whatever may be in some predictive models such as screening guidelines, screening criteria.
Thank you, Chris and Dr. Hoffensberger, for your insight there. I think that perfectly answered the question, and that is all the time that we have for today. But I do want to once again thank Tiffany, Chris, and Dr. Hoffensberger for their excellent presentation, and Optum for sponsoring today's webinar. Please enjoy the rest of your day, and we look forward to having you join us for future webinars.